You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hello, and welcome to this episode of International Perspectives on Chronic Ocular Surface Pain. I'm your host, Anat Galor. On this series, clinicians from around the world are going to comment on some of the under-discussed aspects of chronic ocular surface pain that are sometimes glossed over. For our final episode of this mini-series, we'll examine the clinical journey of a patient with chronic ocular surface pain, or COSP for short. This is the final episode of our first season of this mini-series. And if you like what you've heard in this episode, go back and listen to the first two episodes, which can be found earlier in your podcast feed. First, let's introduce our panelists. Dr. Clara Chan practices at the University of Toronto. Dr. Chan, thanks for joining us.
Thank you for having me.
And Dr. Sheri Rowen, who practices at Envision Eye Centers in Newport Beach, California. Dr. Rowen, I hope I said that correctly, and if I didn't, please correct me. But either way, Dr. Rowen, thanks for coming on the show.
Oh, you did a great job, Anat. Thank you very much. It's a pleasure to be here.
This episode is going to be a little different than our first two. In this episode, we're going to hear from a patient who we'll call Isabel. We've changed her name for privacy purposes. Isabel spoke with our producer, who clipped a few segments of her interview for us to listen and respond to. Isabel is a 38-year-old woman who lives in Mexico City. She's been living with some degree of ocular surface pain for 18 years. When she first saw an eye care provider in her early 20s, a blepharitis regimen and course of topical corticosteroids resolved her condition. She returned for this treatment approximately every 3 years until it stopped working. Let's hear from Isabel.
Since this doctor could not help me this time, I went to many eye doctors. I live in Mexico City. One eye doctor I remember told me that this was going to have something I have to live with the rest of my life, and there's no cure. And it really scared me because the symptoms I was feeling were causing me a lot of anxiety because I could not live my normal life. I couldn't be in the wind. I couldn't do many things that I used to do. I remember I was in my closet crying all day because I could not stand feeling my eyes.
Isabel went to 7 or 8 eye doctors, and her experience was frustrating.
Some told me I was crazy, that my eye didn't actually look that dry, and the feelings I was feeling were just anxiety, and that I would be fine in a few months, to just stay calm. And they really did not take me seriously.
Let's talk about our approach to patients with chronic ocular surface pain. Oftentimes, by the time they reach our clinics, they're frustrated and have been unable to find relief. So thank you, Dr. Chan and Dr. Rowen, for being here. And I love the fact that we all practice in different parts of the country and the world. And to me, this seems like a pretty typical presentation. So I want to ask you, how do patients present to you? Is this something that you often hear as well, people who haven't been taken seriously? Dr. Chan, maybe you can start with your experience in Canada.
Sure, thank you. We certainly get these patients coming in who are very frustrated. They already know sort of all the dry eye treatments that are out there because they've tried every single one of them. And they're left feeling that their symptoms aren't validated oftentimes. And so one of the first things that when we see them, we want to just reassure them that, they're not crazy. These are their symptoms and they're feeling that. And one of the ways that I kind of make it more scientific for them is we can put anesthetic eye drops in their eyes. And I tell them these are numbing drops. If there was something on the cornea that was perhaps a cause for the pain that you're having, if it's numbed properly and the nerve endings are sufficiently numb, you shouldn't feel it. And the test is if we put the numbing drops in and they're still able to replicate the same symptoms and support sort of what they've been feeling, it does help to validate that, this is sort of a scientific way that we've confirmed that they're having this chronic ocular surface pain disease. And just kind of listening to them and just letting them almost vent. You kind of feel like an ophthalmologist and a psychologist at the same time a little bit with these patients when you first meet them, just to make them feel comfortable so that they can trust you with your suggestion.
That's great. Dr. Rowen, what about California? How do these patients present to you?
It's interesting. I think those of us who treat ocular surface disease see this on a daily basis, unfortunately. The patients that come into me, it's usually a typical presentation after seeing 7 doctors or more, and they are constantly trying to find this relief. And I think those of us who are working with these patients have realized that this is truly a neurologic problem now. And that's where we are trying to come up with some solutions. It's neurologic, either peripheral or centrally. And that's a point of discussion that probably would have to be talked about here. But we always hear this no pain, no stain, pain, no stain, or stain, no pain. You know, there's all of these presentations, unfortunately, for patients, and we are trying to find the causes of why they are having this horrendous problem and this discomfort. So yes, we are all in this together, and these patients typically present just like this, unfortunately, all the time.
So Dr. Chan, what causes your light bulb to kind of spark up and say, hey, I think I'm dealing with someone with neuropathic pain? What do you look for on exam or history that helps you figure out what to tell the patient?
Right. So sometimes there is sort of an actual incident, whether it was a recurrent erosion syndrome that triggered it, or they had prior surgery, whether it was cataract surgery or refractive surgery. Sometimes it's just a patient who's had a lot of dry eye problems and blepharitis, and sort of tips them over into this chronic pain phase of things. So there's various triggers that you can actually ask the patient about and pinpoint. But then you've just got patients who are referred in, and their referring doctor has already, worked them up and treated their dry eye and blepharitis. And these patients who just really, they're much more symptomatic than you would expect when you examine them on slit lamp exam. Like that whole, there's no stain, but there's pain. The other thing that is important, I think, is that we always should check with vital dye staining, because we do know that rose bengal or lissamine green will highlight conjunctival staining prior to fluorescein staining of the cornea. So perhaps this patient does indeed have dry eye issues, and it's just too early for them to show signs on the cornea. So you do always want to rule out dry eye and still optimize that element of things and treat any inflammation that's there. So at least, if patients who have not potentially been treated yet like that, at least that's one first step to be made. Because a lot of times these patients come in and they've almost given up on everything, and you kind of have to restart the clock back to time 0 and take baby steps, reintroducing them to sort of all the elements that will hopefully help.
So Dr. Rowen, let's say this is pain without stain. It's the real deal. Where do you start?
Well, as Dr. Chan just mentioned, that important to do an anesthetic test, first of all, to see how they respond. Does that pain go away or not? And I think that that's one way to be able to diagnose that. Secondly, now when you think about DEWS-2, the neuropathic component of ocular surface disease has finally been included. We are realizing that there is a neuropathic a neuropathy of sorts. It's a neuropathic problem. And because of this, it's a difficult thing to know what you can use to be able to make this patient more comfortable. We are looking at different compounds that could actually help the nerve endings themselves. There are some things on the market already that we can use, and there are things being tested. But these are really difficult patients, if it is truly neuropathic, to be able to isolate it, diagnose it, and treat. But we do know in many of these instances, there's inflammation, there's evaporation, there's so many multiple components. So at this point, unless you have other medications at your disposal, the most important thing is to really comprehensively treat this with anti-inflammatories, with potentially nerve growth factors, with other components of the tear film that would be, maybe amniotic tissue, anything that could support getting the tear film back to some level of homeostasis.
Great conversation, everyone. After the break, we'll hear from Isabel, who luckily eventually found relief. Welcome back to the show. Let's return to Isabel. She finally found some relief when a clinician in Mexico City advised that she start a regimen of amitriptyline. But a few months after she started taking amitriptyline, she found out she was pregnant. She halted the medication, underwent severe ocular discomfort during an otherwise uneventful pregnancy, and immediately resumed amitriptyline therapy after birth.
Started with amitriptyline with 25 milligrams a night. And after a few weeks, I started feeling a little bit better, but not very good. My anxiety was through the roof. I also combined with my hormones of the pregnancy, etc. So my eye doctor told me, go and see a psychiatrist because you also need to combine amitriptyline with a medicine that helps with your anxiety. So I went to see a neuropsychiatrist because other psychiatrists I saw, I also went through several psychiatrists because they thought I was crazy. They did not understand what eye pain was because they have never heard about it. And finally, I found a neuropsychiatrist, which is like a neurologist psychiatrist. So they understand what pain is. And he gave me Cymbalta, 60 milligrams. I think it's milligrams, but 60 a day, combined with the amitriptyline.
Then Isabel's eye doctor moved to Canada, and she had to resume a search for a new doctor. After appointments with 4 or 5 different clinicians, all of whom reported that her cornea would not stain, but offered little in the way of a solution, Isabel finally found someone in the United States whose approach offered relief.
I had a great rapport with her also because she really understood what I was going through, and that made me feel calmer. So I went up to Miami to see her, and she said the same thing. I mean, your cornea does not stain at all. What I have is conjunctivochalasis, which is the conjunctiva that folds a little bit. And I have it on and off. It's not always there. I have it only when I have inflammation. And when I don't have inflammation and when I actually feel good, I don't have the conjunctivochalasis. So the only thing of my eye that stains is here on the side when I have the conjunctivochalasis.
Surgery was ruled out given the transitory nature of her conjunctivochalasis. This clinician offered an additional medication with impressive results.
With my mix of amitriptyline, Cymbalta, she gave me Lyrica. I think in the States it's pregabalin. And that the day after taking the Lyrica, I did not feel my eyes at all. And I told my husband, oh my God, what is this miracle that I do not feel my eyes?
Some days are better than others, but after nearly a year of treatment, Isabel has reported longer stretches of relief.
Before it was every single day feeling bad 24/7. And then it was one day yes, one day bad. And then it was 4 days okay, and then 4 days bad. And now it's been like 2 weeks okay, and then a few days bad. So I've had ups and downs, but I have my life back already. I mean, I go on vacation, I go outside with my kids. The other day I was at the beach and I was at the boat and the wind did not affect me at all.
I think this opens us up for a useful discussion about how to approach patients with chronic ocular surface pain. In this case, a diagnosis of conjunctivochalasis and a course of pain medication led to success. I wonder what this case might say about future patients we might encounter with similar issues. Dr. Chan, what have you found to be most useful? I think you made some great points that most of our patients both have nociceptive and neuropathic components, and they both need to be treated. What do you specifically focus on when treating neuropathic pain? Is it something you treat yourself? Do you treat with another specialty?
Yeah, so definitely when the patients come in, I try to advise them that this is a complex disease, and I can, from the ophthalmic side, try to at least optimize things from a local basis. But then once they need also, further expertise from either a pain specialist and psychiatrist likely, then I can explain to them that, you're going to need a few people to help you because it's not my area that I'm able to. So from the ocular side of things, certainly ruling out any mechanical cause for their symptoms, any sort of, actual corneal pathology as well. I think the case with Isabel really nicely illustrated how likely she has obviously the neuropathic pain, but with the addition of the conjunctival chalasis issue, with that being managed, like it can definitely help reduce symptoms. I've certainly seen patients where they also have the neuropathic pain, but then they have really bad Demodex blepharitis, for example, or they have really bad rosacea blepharitis, or they also have recurrent corneal erosions. And so, you want to be able to actually identify the things that we are able to treat from an ophthalmic specialty, but then these patients have to understand that it goes beyond that. And so with that, they do need the assistance of other experts who are able to comfortably prescribe the anti-anxiety medications, the neuropathic pain drugs, things like that. I don't feel comfortable prescribing those aspects of things. I have referred patients to we have medical marijuana clinics, and so that's one avenue that for patients who kind of don't want that label of needing to see a shrink, for example, that's sort of one step before they're willing to go to a medical marijuana clinic to see if that helps. But from an ocular side, certainly you can prescribe, and I'm comfortable prescribing all the dry eye therapies and then all the nutritional supplements. You have your serum tears, your platelet rich plasma, or your platelets rich in growth factors. Even we have that available, amniotic membrane. And for a few patients who, they're willing to try, gabapentin is something that I've prescribed as well, but that's sort of the only oral drug that I'm comfortable with. But certainly these patients need a good discussion about how from the eye side we can help, but they certainly need additional care from the folks who are more comfortable with the neurologic treatments.
I think you raised some really great points. One of the things I'm most excited about is we're thinking about chronic ocular surface pain more holistically and not just assuming it's an ocular surface issue, but also not just assuming it's a nerve issue. And I do think that in most patients, it's both. And whether we feel comfortable treating the neuropathic component, doing a great exam to find those nociceptive contributors, and we're really good at treating those, and then becoming maybe more familiar with the neuropathic treatments or finding partnerships that we like. And I think it's just that recognition that pain can have multiple contributors, I think is really the first step to doing a better job treating our patients. Dr. Rowen, do you agree, disagree? What do you find in California?
Well, I totally agree with this. I think that, first of all, the relief of a patient feeling that a doctor has understood what they're saying and has listened and possibly identified the problem is probably going to work wonders. Not that it's going to be curative, but that anxiety of no one being able to help them, for one thing, can be alleviated. So understanding and recognizing that even though you don't see anything, either on fluorescein, lissamine, or rose bengal, because we use all of those as well. I always do fluorescein and lissamine on every single person. And you find a lot of information on vital dye stains. But if you don't see that, most doctors just say, I don't see anything. And then the patient feels abandoned. So first of all, we have to recognize that we cannot abandon these patients, that they really have a real problem. It is neuropathic. And we have to work with other specialists, as Dr. Chan said. I have used the gabapentin as well. But anything, any psychotropic, any other drugs, I'm not comfortable. It's not my area of expertise, so they would have to see someone else. But usually, we can get them some help. I have actually, interestingly enough, used some scleral lenses in these cases with solutions underneath them, and that seems to have just, at least the nerve endings superficially, it's helped a little bit, where they were covered enough so that those poor nerves weren't crying out in pain. But again, what people don't understand is that there's central and peripheral components of this. And I think as we do more science and as we do more research, we will understand those two separate parts of the problem and then be able to help patients with better treatments.
I think that was a great discussion. And Dr. Rowen, I love your point. The bottom line is we can't abandon patients, no matter whether they have stain or they don't have stain. And I think that that is a real take-home point, along with thinking about both the ocular surface and nerves. And, we can't always see nerves, but we have to think about it when we approach a patient with chronic ocular surface pain. So I want to thank Dr. Chan and Dr. Rowen for coming on the show, and want to thank the listeners for joining us too on this 3-episode journey.